Thank you, everyone, for joining us for the Physician Alliance's Helping Physicians Finish Faster, Making More Time for the Things That Matter Most. We're so excited to introduce Dr. Scott MacDonald, a practicing primary care internist who has extensive experience with electronic health records and is the medical director for UC Davis's EHR. In his role, he's the primary lead, optimizing the system and also leading key initiatives across the organization that include physician training, change governance. So with that, I'll shortly turn over the call to Scott. I just do want to let everyone know that the line is closed. We encourage everyone to hold questions until he's completed his presentation. You can also weigh in with the open chat line with any questions you have. We will hold those until he concludes his presentation. Thank you for joining us, Scott.
Thank you for having me, and a good day to everyone on the call. So thank you for the introduction, and I think she introduced me just fine. So I'll go ahead and get started. Make sure my slides advance here. So today I'm going to talk about what we've done at UC Davis Health, talk about the importance of physician training, share the processes that we've used to help our physicians use the tools that we have in our system optimally so they can get their work done quickly. We also do a lot of work with optimizing our EHR system as we sort of right in parallel and in the same engagement as we do with the training sessions. And also talk about how we've used data to drive all of the above and share some of the data on the outcomes that we've witnessed and observed. I don't really have any conflicts of interest in this area. Tell you a little bit about UC Davis Health. We're an academic health system in Sacramento, California. We're sort of the northern and easternmost UC, University of California medical center, and as such, our catchment area is quite extensive, and we take care of patients from many counties in the whole northern half of California, many patients from Oregon and Nevada as well. You can see some of the statistics about the size of our facility and who we have working for us. And we also have a Connect hospital, which is a terminology where we host the EHR for a community hospital up in Placerville, up in the foothills of the Sierra Nevada, with 190 physicians there. We're a level 1 trauma center, the only one in the area. We do extensive telehealth services all throughout California and neighboring states, and lots of other things, but I think that's enough for this presentation. Outline of our Physician Efficiency Program, or PEP for short. We're going to talk about the two main components of our program, which is the training and the system optimization, then go over the outcomes and the lessons we've learned. So the organizational driver, really a lot of it's the recognition of burnout. That's 40 to 50% in some specialties amongst physicians. UC Davis is really taking an interest in trying to minimize the amount of burnout that we have amongst our providers. We recently hired a chief wellness officer who one of his major work efforts is going to be collaborating with me and other informatics leaders to decrease the amount of burden that the EHR puts on our physicians, as well as other roles around the organization. A lot of this is due to the intrusion of desktop medicine as opposed to the face-to-face medicine that I think all organizations that have put in an EHR have seen over the last 10 years or so since meaningful use has come into the picture. There's lots of studies out there showing up to 50% of clinic time is spent interacting with the machine rather than interacting with the patient. I would like to call out that that's maybe not totally fair to EHRs in general, because a lot of the things that physicians are doing in the EHRs are external mandates, and sensibly a lot of organizations have leveraged their EHRs to help them comply with these external mandates, such as quality measurement reporting, gathering data for operational requirements, and of course we can't neglect all the requirements for billing and what we need to document to support different levels of billing throughout our system. So that's something to keep in mind as you look through a program to try to optimize EHRs, is to identify what's really the EHR itself and what are external issues that you may or may not have a lot of control over. And as a result, where the rubber meets the road for a lot of these concerns is turnover and retention. Burned out physicians tend to leave practice at a higher rate. We have several physicians that have gone on to work for insurance companies, for example, because they don't have to deal with the stresses of primary care primarily. And you may be familiar with various statistics ranging from $250,000 to $1 million of cost to replace a physician who's left an organization. So there's real hard ROIs in this area, and if we can have an impact on those, then a program like this may well pay for itself. So what helps? So looking at some of the data, there's not a lot in the peer-reviewed literature, but most of you may be familiar with CLASS, which historically has mostly been an organization that provides kind of report cards for EHRs and the quality of various EHR vendors. But in the last year or so, they've reached out and formed a collaborative with a number of healthcare organizations with some surveys and looking at what are the real drivers of physician satisfaction and happiness with their EHR. And one of the strongest findings in the data they have is that time spent training per year and the amount of personalization an individual has done in their version of their EHR are the strongest correlations with being happy with that aspect of their job. And then anecdotal, as I've been in this position for now going on 14, 15 years, it's one of the great complaints I hear from a lot of my colleagues about why can't the EHR just do this, or I'm so frustrated by the amount of patient messages I'm getting. And I'm sure many of you have had the same experience. So there's always a clear reason, there's definitely a clear reason to do something to help our colleagues. And so this is something that last year, about a year and a half ago, we did a pilot program sort of by the seat of our pants with some volunteer analysts from IT to try to do sort of an informal program with a few clinics to see if we could at least qualitatively improve the experience with the EHR. And we picked 2 primary care and 2 specialty clinics. And we spent a few days with each of them. And based on excellent feedback we got from the physicians that we worked with, finding the interaction helpful, we got funding for a full program. And we've just about finished with our first full year of the program since it started, and have done a few dozen clinics, both full-time primary care physicians in our community-based clinics, as well as a lot of specialists in our academic clinics. So here's a little bit about the background of our program and our EHR. We've been live since 2004, and as I said, we've been on the PEP program for 11, 12 months now. And this data is old, a couple months old, but we're probably up to at least about 100 residents by now, and we've probably done about 130, 140 faculty and fellows. And we're planning to get through all of our clinics by early of 2020. So what does one of our engagements look like? So we basically have 2 teams of 3 people each, and we also have a supervisor who does an amazing job really running the whole show. And each engagement has 2 trainers and 1 builder, and they work in the clinic for a few weeks depending on the size of the clinic. We're there minimum 3 weeks, even if it's a clinic with just 1 or 2 providers. And the main thing that drives the length is allowing enough clinic time for our trainers to spend a half a day one-on-one training each physician in that clinic. And then on the optimization side, I'll get into more detail on that, but at the same time that the physicians are being trained by the trainers, certain members of the physician staff at that clinic are working with the builder and determining what would be a helpful change to the EHR that can be implemented in a relatively quick turnaround time to help improve their efficiency with the system. So go into more detail about the training. So we kind of have 2 flavors of training, and both happen at each clinic engagement. 4 hours, like I mentioned, individually tailored, and I'll go into more detail about how we tailor it, one-on-one training for each physician. And then we also have what we call Pep Talks. The team, by the way, is called Pep Squad, and so this affords us lots of nice marketing opportunities. Anyway, the Pep Talks are basically brown bags or group meetings, oftentimes at lunch, that we get catered to encourage attendance. Sometimes we'll do them first thing in the morning, rarely at night, but basically it's driven by the availability of the physicians in that clinic, depending on their specialty and what their clinical duties are. So the one-on-one training sessions are held right during clinic time because we want to have the training be really relevant to actual clinical care. And so what we do is we block down their schedule for that 1/2 day and basically block every other patient slot for that half day. And because of this, in a lot of our academic clinics that are very impacted, we have to go in 3, and now we're even going to 4 months sometimes to make sure we block those schedules before they get filled up with patients. Some of our clinics offer compensatory RVUs for the time that they're not seeing patients that day, but that's sort of up to the leadership in each clinic. And so this is the individual tailoring part of it. So basically the first week of an engagement is a lot of the preparation where the trainers are gathering data and developing the individualized curriculum for each provider. So they'll do some shadowing during that first week. They may not be able to get to everybody, but they'll spend some time in the clinic and try to pick out some volunteers who are willing to have the trainers observe them for a few minutes, ideally in the exam room if the patient consents to having a visitor. And so they'll take some notes and look for certain commonly seen bad habits that can be corrected. And also this does provide a little bit of a dialogue where the physicians can bring up some issues that they or their colleagues in the clinic may have been struggling with for some time. And so these are items that can drive the individual training curriculum. We also use the provider efficiency profile, which is data that we get from our vendor. It's moving to a new format. I can talk about that in questions and answers if people have questions. But we get a lot of data about how much time providers are spending in the system. Next most important is what kinds of things are they doing during that time that they're in the system, and how much of that time is outside of clinic hours. That's very important too. So we want to make sure we're kind of sensitive to the physicians who may be spending a lot of time working on charts in basket messages at late hours in the night, and try to focus on some of the issues that they struggle with the most. The provider efficiency profile also shares with us what tools a given provider may or may not be using that might be appropriate to teach them. And so that's a very useful piece of data that we use in forming our curriculum. We can also do some other analysis of the system, looking at the provider's user record in the system and, again, getting a richer picture of how they have their personalization set up, what kind of tools they have made available to themselves. And then we also have a pre-engagement survey. And this is something that we try to get them to complete during that first week when we're doing the prep. And there we're also seeking data on their self-rated efficiency with the system, happiness with the system, and how it's configured. And we also ask them, what are the things that frustrate you the most about the EHR? And even though a given provider may be pretty efficient with a given feature, if they're really frustrated by it still, that's something we want to address and try to decrease their frustration level, because as we know from the literature around burnout, the more empowered and self-actualized a provider is, the less likely they're going to get burned out. So we take all these different data sources together and we put together called an individualized physician efficiency plan, the IPEP, and this provides a couple different serves a couple different roles. One is it gives us a nice, clear, concise list of the tips and tricks we definitely want to teach that provider during their 4-hour session and make sure we get through all of those. It also allows us to do some follow-up work to see down the road we have some breaks in our schedule where we can go back and check in with some physicians that we've worked with in the past, mostly the people that are most at risk, the people that were working the most hours after clinic hours. And we can go back and see how they're doing and if they're actually using the tools and the shortcuts and the behaviors that we've recommended that they try. It also allows us to capture key information that comes up during the dialogue that our trainers are having with the physicians. Oftentimes they'll be a great idea that the physician has to say, can we do this? Can we change EMR to make it do this? So we can record that and take that to our builders, sometimes right within that same engagement, and make changes on the fly. The other thing it does is keeps the visit focused. One of the problems that we've had sometimes is some physicians who are very frustrated with the system oftentimes will take this as an opportunity to vent. And they can spend a lot of their precious training time and precious training resources complaining about the system, which is often a not productive use of time. So we try to use this as a way that we say, this is what we need to focus on. I'll listen to your complaints. Let me write them down, and we can deal with them after this time. But let's use the time that we have productively, and because I've got lots of things I can teach you to really help improve your efficiency. So this is a tool that's really critical for our interactions with each physician. And I've kind of talked about these already. I'll call out the third bullet a little bit more, which is oftentimes we've seen the same sort of issues come up across and within clinics, and it may not be something that we can fix during a short 3 or 4 week engagement, but oftentimes it's something that we can bring to operational or health system leadership to make changes in other areas of how we do business that can help efficiency. So it's been useful from that standpoint as just sort of an environmental scan, something we didn't anticipate. Okay. Pep Talks, again, these are the group sessions that we do roughly weekly. It's driven really by the physician schedule, so we're very flexible, and if they want to have 2 in 1 week, do 1 in the morning, 1 in the afternoon, we'll work with them. And we tend to focus on topics where a lot of people are struggling. So instead of, and again, we derive this from the research that we've done during that initial week. And if we see that most physicians are really struggling with in-basket, for example, especially that's an area that relies on teamwork. And so maybe we'll have a session on how to use in-basket effectively. And if it's something where we feel that maybe it's how the physicians and their medical assistants or administrative staff are messaging inefficiently, sometimes we'll invite them as well so we can help create a dialogue about what are the best workflows to follow to improve efficiency. Widescreen is a new Epic functionality that takes some getting used to, but it's a more efficient way to do your visits. And a lot of people don't use that, so we do that for most of the clinics right off the bat. And the other thing is that those topics are often really driven, again, by the audience. And we try to do, if something, they really all want to hear a session about how to use voice recognition, for example, we'll trot out our presentation on voice recognition. Now that we've been doing it long enough, we have a nice library of presentations and talks we can do. And you can see some of the other examples we've got there. Efficient ordering is another one. Haiku and Kanto are the 2 mobile applications for Epic that are helpful if you're on a call away from the office. And they also include the voice recognition, one of the options for voice recognition that we have here, which is also in addition to Dragon, which a lot of our providers use. Pep Squad working location. Now, they do have desks back at sort of the mothership in our IT building, but we try to encourage them to be in the clinic most of the time that they're during engagement. Oftentimes, they'll be back at the mothership that first week and a day or 2 during the training weeks. But even the builders, we like to have them out in the clinic close to the providers so that they can do additional sort of ad hoc training when they see people. Oftentimes we'll station them like at a nursing station or someplace that's very visible to the physician, not necessarily squirreled away in the conference room, out of sight, out of mind. So they're just right there. So we can provide a lot of additional training when physicians realize that they're a useful resource and they have a question and they walk out of the exam room and there's Jesse. Oh, I'll ask Jesse. So that's been another big satisfier for our physicians. And because our staff are right there, that as we add new functionality into the system, our training staffs are right there showing how to use the new features. All right, system optimization. Okay. So a real key to our success here, I think, has been getting a good subject matter expert, or SME, assigned from each clinic. And this is somebody that should be a little bit more technically adept, but yet somebody who has been there long enough, who knows the personalities, knows the workflows, sort of an informaticist in training, or with somebody with some informatics potential, if you know what informatics is all about. And that person works with the assigned builder pretty closely for the couple weeks they're out there. Talk about what problems the clinics might be having, and if there's some EMR changes that could be put in to improve those, to solve those problems. They're responsible for being the interface with all their fellow physicians and taking sort of enhancement requests from them and prioritizing those with, because oftentimes there's a lot more that's being requested that can be completed during those couple weeks. And then they'll work with the builder throughout the time our team is out there. We try to follow a sort of modification of an agile build process, if you're familiar with that from general IT theory. And so our builders basically will build a mock-up or a draft of a change, run that by the SME, sort of grab them in between seeing patients. Sometimes we'll have a formal meeting, but a lot of this is just small changes, quick conversations in the hallway. And then once they've got a pretty good product, then that SME can sign off on that, and then that change will get moved into our production system. We start with a build menu. We have a number of changes to the standard functionality that we know we can build quickly and safely. That's not going to affect other users across our health system. So we tend to start with this to give people some ideas about what we're capable of. You can see here some examples of epic jargon. I won't go into it since a lot of you people may not understand if you're on Cerner or another system. And because these are sort of standard quick-to-build things, we've got an agreement through our IT governance process that these items don't need to go through the standard review that other changes will. So that's another benefit. Not only are they easy to build, we don't have to get approval, they tend to affect only the clinic that we're working with, and so these can get done quickly. But frequently there are unique problems that a clinic will have, and we encourage people to share with us ideas or problems that they would like solved, and we will work with them on trying to build something in the system to help address those, in addition to some of these other standard items that we can build. Some of those may have to go through governance and special approvals, but in my role in the governance system, I can often help facilitate getting those through the system. Here's just bigger pictures, so for all of you folks who are on Epic, you get a sense of the kind of things that we do build. I won't dwell on that now. We organize the changes basically into two groups, two batches, if you will. We have a starter pack, and oftentimes we'll start with this the very first week of engagement. Now these are build changes that we perhaps built for another clinic that have found to be pretty useful. And we'll talk about these a little bit during that first week with the new clinic we're working with, just to let them know roughly what it is and just to make sure it's not going to break any kind of custom workflows that they may do. If we've worked with the same specialty elsewhere, we'll try to bring content from that specialty on board during that first week. And like I mentioned, anything that we built from another clinic that we feel would be appropriate for the current clinic. And during that first week or two, we can train on that starter pack. Pretty easy to put into the system, all pre-approved. And then the booster pack is really what the SME has worked with our builder. So they're new additions to the starter pack, and again, our Pep Squad's there to support those new changes. And then frequently what we'll do then is then the content from this clinic's booster pack is we can roll into the starter pack for the next clinic. So we hope that as we get through most of the clinics, we'll have a nice package of enhancements to the system that everybody will have. We also do what's called we go back every couple engagements. We actually take a week off from actually working one-on-one with physicians. And this is our sort of build sync-up period, we call it. And so clinics that have gone live earlier in that block of clinics that may be missing some of the content that we developed for the subsequent clinics, we'll go back and give them sort of a new booster pack. So every few months we sort of sync everything up within a given specialty, and everybody's on the same page with the same standardized functionality that we built. So that's basically the pretty high-level view of what we do. Now I want to share a little bit with you of how we've done. Okay, so first I'm going to talk about efficiency. So this is self-rated efficiency based upon survey data. I mentioned before that we do a pre-survey during that first week, but we also have a survey that we give a couple weeks after we leave. And so this is just a Likert scale, 5-point Likert scale, and these are all, everything I'm going to show you here is statistically significant. And so we've got a 24% increase in self-rated efficiency on the Likert scale after we've been out working with them. And we also use some net box scores. Most of you are familiar with Press-Ganey scores, the top box score for physician or patient satisfaction. And with a net box score, we basically take the two top scores minus the two bottom scores, the 4s and 5s minus the 1s and 2s. And so that gives us another way of looking at the sort of the shift in self-rated efficiency. So we see here that a large portion of people are rating themselves, poorly in their efficiency before, and it's gone way up, and a lot more people feel confident in the system. And when we break that down by different types of functionality in our AHR, we see kind of across the board, we see lots of areas. So it's a pretty generalized improvement in efficiency. The higher numbers tend to be the topics that we tend to teach more and emphasize more in the training, and that's just reflected in how much their self-rated efficiency goes up. Satisfaction with the EHR system itself, that also improves significantly. See the less impressive here, but a 12% increase. We started from a higher baseline here, so there was less space to go up. And you can see that by the net box score that 40% of our, so a lot of our physicians were reasonably happy with the system to begin with, so have less of an opportunity to go up. But still, significant improvement statistically. Then Pajama Time. This is a bit more where the rubber meets the road, I think, since a lot of what we're focused on was trying to get people out of the office faster, spending less time in the system, and so they have more time for their families, for their hobbies, whatever matters most to them. So part of our survey instrument is what's your feeling of acceptability of the amount of time you spend? Kind of irrelevant of what the actual numbers of hours you spend in the system is. Are you happy with it? Do you think it's appropriate? So that's the question we're asking here. And we've had a 26% increase in that. So even if physicians were still spending some time working after hours, they felt more in control of it and happier about how much time they were spending. But what about hard numbers? Well, that's probably my most favorite number with this is 25 hours a month mean reduction in the amount of time people were spending in the system after hours. Now this is for full-time physicians. Most of them are primary care physicians, and the numbers are not as impressive for academic types who only spend, they only have a half a day of clinic a week, so the numbers aren't as impressive, but they're sort of, but you can extrapolate down to those. But for your full-time physicians, we're giving them a day back a month in their lives. What would you do with an extra day? And then we looked at, well, does it work on kind of everybody in the clinic? So the orange dots here are represent individuals. This was earlier data that we had from the first few months of our organization, and these were just people that had complete data, and we left off some of the folks that were missing data. And along the horizontal axis here is the amount of time they were spending in the EMR after hours before we came out. And so you can see there were a number of people that were spending 60, 90 hours per month in the system. And on the vertical axis, it's the amount of after-hours time change they had after the system. So if we had no effect on their time after hours, they'd be right at the 100% mark. And below the line means that they're spending less time in the system after we came out. Now, for the people that didn't have much time in the system anyway, you can't get blood from a stone, so we didn't see much change in the people who only spent half an hour a day. So they didn't change much. But then you look at the people who were spending a lot of time in the system, and you see they're the people who really benefited a lot. And so we saw quite a big change in the people that were really spending the most time, and they improved the most. And then we looked at a lot of other things that didn't really change much, so I'll go over those too. We haven't seen a real shift in the level of service coding. We haven't seen a change in the number of encounters that are closed on the same day. A lot of that is because a lot of our physicians already closed their encounters on the same day, so there wasn't much room to move. There's a efficiency score that we get from our vendor. We didn't see that change much. That's a number that has a lot of artifact in it, so I'm not surprised. And then looking at some in-basket measures about turnaround time on how long it took physicians to take care of results and patient messages and the like. And again, pre-engagement, most of our clinics in this data set were finishing everything pretty quickly anyway. So we're going to keep looking at this, and there are some other clinics that we, in fact, just finished with and don't have data yet who have had particular problems with slow turnaround times, and we're eager to see if their numbers may actually improve after we've helped them out with their efficiency and tricks in dealing with messages. So I'm going to go over some high-level things that we learned during the over the past year. One thing is that the leadership support is really critical here, not only for funding to get this team put together, but making sure the schedules are blocked down, making sure that the communication channels are clear so that all the physicians and providers understand the value that we're bringing to them so that they'll engage with us. There have been a few sporadic cases where there was poor communication. Physicians didn't really get us. They didn't know why we were there. Maybe they didn't want to spend their time. They didn't think there was value. So they kind of lost out on the benefits that their colleagues got. So making sure that if you're going to do something like this, making sure that everybody's on board, and especially down to the clinic managers who end up doing a fair amount of the work in terms of communication, making sure the schedules are blocked down, helping coordinate the brown bag sessions. So that's all super critical. The build and the training are very complementary. There's a lot of systems that do training. There's a lot of systems that do optimization. But I think having both together is really powerful, both because the trainers are there so that the physicians can take full advantage of the new functionality that gets rolled out while the team's out in their clinic. But also because we have those trainers who are really working closely with the physicians, we get a lot of great ideas for optimization of the system from them, and we can implement those right because the builder's right there as well. So I think that working those two together really has added a lot of value to this clinic. The integration of the EHR is something to keep in mind, and I'm sure this is applicable to most EHR vendors, Cerner, Athenahealth, etc. That it's really easy to break things. If you make a change in the system for one clinic, you need to work with the analysts on your various teams in IT to make sure that those changes aren't going to have any untoward effect on the rest of the health system. So we have weekly or biweekly meetings with relevant analysts, and we kind of review together what changes are going in the system to make sure that it's not going to break anything. The other aspect to that is we found is sort of this nice spillover effect that sometimes a change that we're planning to make for one clinic really is going to be useful for all clinics. And so we decide, let's go ahead and make that live for everybody, not just the clinic the PEP team's working with. So we've added some value to all of our users that way as well. Okay. And we have to align those with various upgrade efforts. Refuel is a program where we're taking our very custom setup here at UC Davis because we've had it for so long, and we're making it more standard. So on a quarterly basis, we're having significant changes to our system, and so we're making sure that we don't build anything through the PEP team that's going to happen later or get broken by one of our quarterly changes that's coming down the road. That data I showed you about measuring after hours is a tough one. It works great for physicians who are kind of full-time outpatient physicians, but it really broke down a bit when we were looking at residents and some of our subspecialists who do inpatient care, trying to tease out the time when a resident, for example, is supposed to be on night float duty overnight, and pulling that out of the data set as inappropriate after-hours EHR use has been tough. So our data there is a lot less clean, but we're working on it. Program value is perceived differently by everybody. The physicians really want to have that feeling of confidence and mastery over the system, whereas the high-level executives want to see especially in the finance area, want to see that ROI. So messaging about the program, we've put a lot of effort into making sure the messaging is really tailored to the audience that we're talking to. And we also have a real attitude of every engagement we do, we talk to the doctors, we talk to the managers, we talk amongst our own team, and talk about what went well, what went poorly, and we are making continuous improvements in how we run our program with each engagement. And where do we go from here? So we're waiting to hear about our funding request. What we plan to do is double the size of our team so that we can have 4 teams of 2 trainers and a builder, and we want to start going back to the clinics we've been to. A general principle of adult learning is that idea of reinforcement, and we're able to do that to a limited extent now during our build sync-up weeks that I mentioned earlier, where our trainers can reach out to some physicians and make sure that they're using the new techniques. And we also get plenty of requests from physicians just wanting another quick session on either reviewing or doing some new optimization work for them. So we do that every couple months. We have a break where we can provide that service. But we want to create a whole team that's able to do that full time and really emphasize using these new tools regularly. And we need some more manpower to do that. And then the other team we plan to have is to start going on to the inpatient side. So we're making plans for that, and we're going to start working with our hospitalists, then out to the different subspecialists, and identifying what's going to help them the most. And again, we're going to have to keep in mind the sort of difference between the full-time clinician, like a lot of our hospitalists are, and then the academic physicians who may spend very little time in the hospital. So we think in the hospital we're going to be focusing quite a bit more on residents who do the lion's share of the work on the inpatient side. So I think that's the end of my presentation. You see my contact information there. I'm happy to fill in some details if you are interested. And then I will open it up to questions. I think I'm just going to address these by reading the ones that have come through. Is that correct, Aisha?
Yeah, and there are actually some that are just logistical questions, but I wanted to encourage the folks who are still on the line to ask them directly. I see one is, how long has UC Davis been on Epic?
The clinicians have been using it for notes and orders in the ambulatory space since 2004. We started building in 2002, which is sort of a read-only version for labs and dictations. And then our inpatient folks have been using it since about 2008.
And the other question that I will go ahead and have you field, because some of these are logistical, don't want you to be bothered with them, is just about the use of Epic and the tools that you might share. I'm also going to go ahead and hand it off to our operator to just give everyone some instructions on how to use the audio for Q&A.
And if you would like to ask an audio question, please press the star key followed by the 1 key on your touch-tone phone. That was star 1 to ask an audio question. And we currently have no audio questions in queue.
Okay, great.
Okay. I see one here just from Colin Lamb. Do you see a role for this process prior to an Epic Go Live in engagement and planning? I mean, our focus really is on experienced users, but what I would say to that would be most helpful is to plan for something like this during Go Live, because when a physician or probably any Epic user or EHR user first starts using the system, they get a fire hose of new information coming at them. It's a lot to take in. It's a big change to your workflow. People are just trying to get the basics of how they can get through their day and get their patients taken care of. And it's not till a few, certainly weeks, probably months later, that they've got the basics down in such a way that their brains are capable of taking in some more information. So what I would recommend for a newly installing person is to have a program like this in mind, but don't wait 14 years to do it. Plan to do it within a couple months, because that's going to really provide the value and that information when they need it, and also when they're ready to take it in.
And Scott, I wanted to draw your attention to an earlier question that was posed about, I know you shared your contact information, but Sandra, if you're just to lead into your question about whether, Scott, you share these tools with other organizations.
And you're talking about like the IPEP form or the enhancements to Epic that we've made?
Forms.
Okay. Yeah, I think we can probably share some of those if you want to contact me. I can share those.
And I see some other questions that have come in.
Yeah, the SME, okay, the question from Robert Schwartz is the SME a person who is in a practice, provider, administrator, or nurse? Typically, our program is really focused on providers, a bit more on physicians, but we certainly are very engaged with residents and fellows. Typically, the SME is going to be a physician, but there's been a few cases where nurse practitioner has been who's very, very active in the workflows of the clinic. We've leveraged them to be the SME. But usually it's not going to be nursing or administrator. They're not close enough to the provider work to be able to provide the right feedback to the builder. All right, and there's one from Vinadini Sriram. Can you talk about how you manage to maximize staff scope? For example, how much do you have your medical assistants do in your EHR? Yeah, so that's something that's sort of explicitly not part of the PEP program. Re-engineering workflows and changing policies and procedures around who can do what tasks is kind of beyond our scope. A lot of those are long-term kind of governance decisions to be made, and we work on those outside of the PEP program. But we do share observations with the administrative leadership of each clinic we work with. Frequently, we've seen kind of odd workflows, and we see physicians doing things that other clinics have their MAs doing. And we do have a set of guidelines for what LVNs and medical assistants can do in our organization. So oftentimes we'll share those with the leadership to say, hey, your MAs can do X, Y, Z, and they do them in all these other clinics. and then we let them actually do the change management for that. So that's sort of a fringe part of our scope. So we'll point out problems, but we won't make those changes. Okay, Pep Forms. Okay, and then Chantel Bolel Torres. Did your clinicians go through Thrive training? And no, we haven't. This is all homegrown thing here. And does this program supplement Thrive training? I think it would. I think any sort of standardized training that you might give your physicians that's sort of out of the box from a vendor would be helpful, as long as they have the time to do it. But I think the real value of our program is the real individualized nature of the curriculum we do. And it tends to be a lot more meaningful because it's really based on the very specific things a given individual is struggling with. Next is, does your organization have physician builders? Yes, we have just a couple. We're early in our program of developing that. We've got one ED person, one pulmonary critical care person right now, but we're about to open up sending some primary care physicians for that, but we're early in it. And they're complementary to this. And part of my role is to kind of coordinate anything that a physician builder might be working on so that we don't have overlapping work being done between PEP and physician builders. But that's going to become more of a complex thing as time goes on and we get more. I think I'm caught up with the written questions. Are there any other oral questions?
As a reminder, if you'd like to ask an audio question, please press the star key followed by the 1 key. That was star 1. We have no audio questions at this time.
Okay. All right. Lee Saltzgaber has typed in something. What are the most frequently cited efficiencies that produce the highest clinician satisfaction that were identified post-PEP? Well, I can speak a little bit in generalities here, but again, I think a lot of it is physicians learning the tips and tricks that help them with the areas that they struggle the most in. That individualization has really been the most important, and that's different for everybody. One of my pat sayings is everybody struggles, but everybody struggles in their own unique way. And identifying those unique ways and helping those has been the most powerful. But in general, I think we've seen a lot of benefit from getting people moved over to the widescreen view. And for those of you who don't know about the Epic widescreen view, it's what the current design of the software is focusing on. There's an old version that doesn't really have an official name, and it just requires a lot more scrolling and clicking and screen changes to be able to use it. So the new version is called widescreen that packs more information into one view. And it's different, and when people switch to that, they have to change their muscle memory. Buttons aren't in the same place anymore. Data's not in the same place anymore. And it's a lot busier. So people have to adapt cognitively to seeing a lot more information on the screen at once. But once they do, all the information they need is on the screen at once. So they have to do a lot less of the clicking and screen changes. So it does save a lot of time and clicks switching over to that. So I think that's been a pretty successful change. Let's see what else. And I think probably a lot around ordering, around preference lists and being able to make custom order panels and customizing preference lists and setting defaults and orders. That's got a lot of traction as well. But again, it's really, if you ask all the different physicians who've been through our program, they're all going to answer that differently. All right. Susan Medeiros, did you have coders on your team? If you mean coders like who can get in and use program cache code on our database, no. But they are all certified ambulatory build analysts. So they're able to modify the system in all kinds of ways. So, so we do have a lot of flexibility with what they can change in the system, pending, of course, approval through our normal governance processes so that we don't affect or change workflows or break workflows for the other departments that we're not working with at the time. So does that answer your question? So if you have follow-up questions, type it in, I guess. Okay. Oh, that level of service codes. Thanks for your follow-up. Lol. No, I was referring to your not increasing the level of service. Did you have medical coders? No, we don't have those on our team. We actually have, there's a separate physician training at training team at UC Davis called the Physician Advocates. They're small, and they're kind of focused, they work out of our HIM department, and they're kind of focused more on physician training vis-a-vis how to document appropriately for coding. So they're available as more an ad hoc resource, but you need to especially request their help if you're struggling with documentation issues, whereas the PEP program MO is to help everybody and to try to raise all boats. But we're trying to collaborate more with that group, and we're hoping in the future that they're going to be, they'll come out either along with or soon after the PEP team is there to help out with the documentation requirements. So that's something we're looking forward to this year. Matt Roars asked what version of Epic we're currently on. We're on 18, the base 2018 version right now. We started this program, we were on 15, and we did a double upgrade from 15 to 18 right in the middle of 2018. And then we're going into the quarterly updates starting next month. And with each quarterly upgrade, we're also bringing a batch of changes from Refuel. So we have a lot of change coming this year. Okay, Kemi Ajayi asked, how did you introduce the program? Did you partner with practice managers to schedule providers or clinics? Yes, that was a super critical part of our success. We talk about the program at various levels. Early on, we talked a lot about it with high-level governance, our medical staff executive committee, our council of chairs. We have an ambulatory care work group that meets monthly, which consists of clinic medical directors and administrative staff from all the clinics. So a lot of the introductory stuff was at meetings like those where we talked about what we had planned. And we continue to present to those groups periodically, just to keep us on the radar, keep the visibility high. There's also a executive kind of steering committee for the program that consists of a lot of medical and administrative leaders around ambulatory for now that will expand to inpatient when we go there. So we keep them apprised of our progress and our successes and our struggles, and use them as a sounding board if we need some high-level support in certain clinics. But where the rubber really meets the road in terms of support is with the clinic managers and administrative officers. So those folks we reach out to 3-4 months before our scheduled time with them, and we have regular email conversations and phone calls in the months leading up to an engagement, kind of making sure they understand what the process is like, engaging their help and getting those schedules blocked down. And then a couple weeks before the engagement, either me or the team director and some of the trainers and coders will go out and have like a kickoff meeting with the faculty of that clinic, so that we're getting down now to the individual physician level to kind of get them excited, get them understanding what we're up to, how we're going to help them. And then the very first week of an engagement, then we have a kickoff meeting with just the leadership of the clinic and really get into the nuts and bolts and make sure everything is ready to go for us. So lots of different levels we have conversations with people across the organization. Next question is from Sandra McIntyre. Do most of your providers use problem-based charting? We haven't rolled that out here, so we really don't use problem-based charting. That's something I've tried once or twice to get some traction with, but it's never taken off here. But something like the PEP program might be a good way that we could help roll out problem-based charting or some new functionality. And as we expand our team, we're thinking that because of the trust and relationships we've built with the organization, that this team's probably going to be emissaries of new changes that are coming, which, you know, in the future might include open notes or problem-based charting. So I think we're building an infrastructure as well. All right, Kemi Jayagan, do you have an escalation process when trainers encounter difficult providers? Yes, this has come up a little bit lately. So I'll go two different things here. One is how do we prepare our trainers for this? So this is something we didn't give them much training yet, but we're trying to rectify that now. So we're working with several different aspects of organization that offer training. So we're having our team go through a crucial conversations course, a couple other classes that are offered by our ombuds office and our human resources training group, and giving them the tools to help manage difficult physicians, doing what we can with the support of our chief wellness officer and some other psychiatrists who are interested in resilience. And we're trying to give them the tools to build that resilience so that they can deal with difficult situations and not take it home with them. From the day one, we've been worried about our team getting burned out as well because they're exposed to so much burnout. So that's something that we're taking seriously and trying to do what we can to minimize that. We haven't had anybody do anything that's, you know, clearly in violation of our principles of community. There hasn't been anything that's been, you know, violent hostile workplace or harassment yet. So, and if that were to come up, it probably would get quickly escalated to me, and I'd have conversation with the leadership in that clinic and with appropriate people in HR, going through our normal channels of when people are behaving badly. And another question there is, have you heard about Epic's personalization achievement levels of gold, platinum, and diamond? And if yes, did you incorporate it into your PEP program, and how? No, we just heard about it recently, so it's not part of PEP yet. The little bit I've looked about that, it covers a lot of the stuff that we do teach. So I think I need to look at it further, but I think it will be well situated to try to leverage that and quantify a bit more where a given provider might be around personalization as it relates to efficiency. So I'm looking forward to getting deeper into the weeds on that.
And so with that, I think we'll go ahead and close out the webinar. Thank you so much, Dr. MacDonald, and thank you to all of our attendees. Do we have one last question coming in? Oh, just a thank you. So I hope everyone enjoyed it. I know we did. Thank you again, Dr. MacDonald.